forward. And this is also following the Lancet that issued the Education of Health Professionals for the 21st Century, all in the last 4 or 5 years. So all of these have come out sort of from 2010, but there's been sort of a rapid progression of calls to teach social determinants of health and structural determinants of health in health professions education. And the best practices that they describe, many of the articles have talked about transformative learning, or many of these National Academy reports. And when they say transformative learning, they're talking about a learning theory that's not about knowledge or skill, but rather about the learner's perspective. So teaching learners how to transform the way they see the world, the way they see their patients, their perspective, and to use new beliefs and new ways of looking at the world to treat their patients. So there's a real focus on introspection, intersectionality, and who the provider is, who the student is, as well as who the patient is. And that is part of transformative learning. And a critical part of that is, like the last on this slide, and reflection. Additionally, experiential learning, community-based learning, community-led learning have been recommended. And finally, to have expert faculty actually teaching this, because it does require expertise. The Educating Health Professionals for Social Determinants of Health report proposed this framework that you see here. It's a framework for lifelong learning for health professions in understanding and addressing the social determinants of health. I just want everyone to notice that there are sort of 3 big buckets here that they identify. Education, which is what we're, I believe, all, that's where we're all coming from. But there also needs to be an organizational or an institutional commitment and true, genuine community engagement to make this happen. And you can look up that report further. And now that's the landscape. It's urgent calls. Why is everyone working so hard to ask us to do this? It's because we need to do it better. And then if you look at the research and if you ask faculty, so I've done different workshops for faculty in this space. Faculty and current background research all mention insufficient curricular time for social determinants of health teaching. Limited funding comes up. Need for experiential learning in the curriculum and true experiential learning in the curriculum that's meaningful is a challenge. Preclinical years are challenging, particularly because it's easier to give feedback real time in the clinic with students about this, but prior to that, just using it as a framework or describing it prior to the patient encounter can be very, very challenging, and that's come up a lot, particularly how to help make meaning for students in the space. And then faculty and students, often this is not a priority for them, and then faculty report limited knowledge in general, despite the fact that they're meant to teach it. And prioritization, especially around the basic sciences, came up in a lot of our background research. And like I said, faculty felt uncomfortable in terms of their knowledge, but also in terms of training in the community-based engagement space. So challenges from the educators in terms of how to do this and follow best practices when we're not necessarily trained to do so. So when we looked at this, we said, okay, let's look at the evidence. Let's see how people teach, what people teach about social determinants of health. And we know the preclinical years are tough. We're looking at designing a curriculum for our medical students, so let's find out what's been published on the topic of teaching medical students about the social determinants of health. I underline published because we find a lot of articles, and I'm going to present some of the ideas to you here, but specifically what has been published is a lot smaller, as you'll see. The methodology we used is a scoping review methodology. Since the literature is pretty heterogeneous, we couldn't use a systematic review. And our goal was twofold. I think one of our main goals is to provide a really nice, detailed resource for educators and to sort of paint the picture for educators as to what's out there and what's been published. And then very quickly, gaps emerged, and we were able to identify those gaps and opportunities for further research. So if anyone is planning on doing a scoping review, you can feel free to email me. It's a pretty long process. What we did in this one is we used our inclusion criteria. We took articles that were published between 2010 and 2016. We started mapping at the end of 2016, or started screening at the end of 2016. And our inclusion criteria were articles that had been published and that had enough detail for the mapping, specifically published in English-speaking schools and in North America. And we piloted this, and then we came out with a data form to determine what do we mean by enough detail for mapping. And so content and topic, sorry, this slide changed a little bit there. Content or topic was the first section. The second was educational methods, timing, educator characteristics, learner characteristics, and then evaluation and funding. And then this, the data presentation that says here is, what happened is there was such heterogeneity in the articles that we couldn't present them all together. There's many different fruit. It's like more than apples and oranges if you look at our articles. But what we ended up doing is we separated the publications that had learner evaluation from the ones that didn't, so that we could present the data in an easier to understand way. And I'll show you a picture of that. Oh, enough detail for mapping, and that was the most important thing there. So this is our flow chart, included only because it's kind of a pretty picture, but also to show you that there were many, many articles that we started with and identified up front. Now, in terms of our data form, so this is kind of a busy slide, but I just wanted to show you how we presented the data. So we identified the author and then spent a lot of time mapping out the different educational methods and then levels of assessment, both at the learner level and at the program level. The second table that doesn't have student assessment just has program evaluation. And then you see that we have additional publication details with the hope that people can use this to supplement their curricula or have a general idea of what is available. So what did we find from our scoping review? 4 authors actually did the detailed review and resolved everything by consensus. And we screened 3,000 abstracts, about maybe 3,500, and then selected 171 full text articles to read, and finally included 22. And in terms of what we found, each section of the data form, the content section was actually very heterogeneous, and so we really couldn't, for each category, we kind of identified the major themes of what emerged in each category and then described them. So for the content section, the first part was pretty basic information, like what are the definitions of social determinants of health and how do they impact your patient. And so it was everybody pretty much had that like first semantic part of it. And then every other part of the content was actually heterogeneous enough or heterogeneous enough that we didn't identify any major themes. The only things that came out were many people talked about, or the majority of people talked about community engagement and local context in terms of content. Then in terms of educational methods, it was pretty much, I'd say 50-50, that everyone had some component of a traditional didactic, but the second kind of category was really experiential learning and place-based, so community-based and clinic-based. And you saw more of the community-based learning in the preclinical years and then the clinic-based in the clinical years. And then a big finding was that less than half of the articles had longitudinal engagement which means more than a year. Less than half the articles had community-based engagement, and then less than half the articles actually applied to all students. So I think there were only about 10 articles that actually described curricula or electives that applied to all students. Everything else was really selectives or electives. And then another sort of minor point that emerged, but we thought it was important enough given best practices, was that there was limited teaching and assessment roles for the community representatives. So the community educator roles were limited and didn't really put the community sort of at the center of learning. Everything that I've underlined in these slides are all the ways of engaging that are in the best practices that have been named as best practices. So 22 were finally included. So our major theme results were that we saw that our second part of our major themes results was there was a real lack of objective assessment. Most of the assessment methodology was actually self-reported learner outcomes, knowledge, and attitudes. I added this medical school attitudes towards the underserved. I just wrote it out here because 2 or 3 people have used it, and I know other people that have used it in the past, and so I did want to share a tool that I've seen. I don't know. It's validated. I don't know how useful it is, but it is certainly something that can be used and that has been used. I'm going to pause for a second here on reflection, because reflection was used both as an instructional strategy as well as for assessment. And they do describe critical reflection practice. And, you know, a lot of these, the National Academy reports and best practices reports talk about critical reflection. So I'm going to pause here, and you can see that transformative learning requires critical reflection, because this critical reflection is where you take the time to have the learner become aware of their own assumptions and notions, and assess and question and criticize their actions, and through facilitation, come to a new perspective or a new way of looking at a situation that ultimately will inform their next action. And so critical reflection practices are described throughout this, throughout the scope and review, throughout the articles. Now, like I said before, the most robust programs, which would be longitudinal, community expert educators, and assessments, were only seen for select students through elective or selective. And the last thing is, we did actually take a look at funding sources, and while many were not reported and they were very varied, so we couldn't describe a major theme, it was clear that there was a lot of external funding in addition to internal university funds or academic funds. And so the question is about sustainability and implementation of these programs if there are short, limited grant funds that have started the program. So next steps, what do we see? What are next steps in terms of research and dissemination? So clearly there's a great interest in the topic, both evidenced by this group that's together on the phone today and the National Collaborative Group, but also, you know, there were 3,000 articles that we found when we first pulled it up, and SCOH had not even been a mesh term it had just became a mesh term in the last 5 years. What else do we see? I think we did a nice job mapping the current research in great detail, and the gaps really emerged, which is that despite this litany of urgent calls and reports, we really need a much more systematic and evidence-based way we need more systematic and evidence-based curricula that we know will benefit all students, particularly because this idea of reaching all the students is really this ultimate goal. Objective assessment methods need to be created and tested, and of course thinking about funding for sustainable implementation. And then what came out through a lot of the research, so even though we couldn't use many of the articles for our mapping, we were able to use the articles to sort of see trends in teaching. And that's what I'll share with you today, is I'll share some frameworks around social justice and social medicine, which have been helpful to me and to others, and I hope to you too, to reframe or rethink, or to frame or think about how we're going to teach this. So you're going to have to give me some feedback on this. I plan on giving a little bit of a history of social medicine to the medical students at the end of this month, and we'll see how it goes, but I'll give you a brief version of this. So what I plan to do is I sort of start in ancient Greece and remind them that in Greek medicine, social class, diet, trauma, social structures, beliefs, mindset, all influence in disease. And then I move very quickly along to Virchow, and I talk about the typhus epidemic and how that laid the foundation for public health, and how his political and social activities earned him the moniker of the father of social medicine. And then I really focus on how he looked at the typhus epidemic, and the root causes of it were actually famine, cold, poverty, and crowding as root causes. And then, and we talk about how he didn't suggest more doctors or more hospitals to treat the typhus epidemic. Rather, he proposed social reform and social reconstruction, including full employment, higher wages, education, et cetera, as ways to treat the epidemic. Then we talk a little bit about the interwar years, where everybody was invested in social medicine at the national and international level, including the United States. And I talk a bit about the division after post-war, the division between the Latin American context and the U.S. Anglo-American context, British as well. That's LA versus AA here, is the Latin American versus Anglo-American divide. And I talk a lot about how we ended up in this sort of individual lifestyle medicine, behavioral medicine path, and then our colleagues in Latin America really focused on social causes of medicine and health. And in fact, they didn't just talk about it in care, they institutionalized it in educational institutions. And so this is the Latin American Medical Association of Social Medicine. It became institutionalized in education and in care, and became part and parcel of that system. And actually, reflecting on that, a lot of historians will say that this split between the Latin American and the Anglo-American context, and this divide between medicine and social health, they say that what suffered in the end was the notion of social medicine. So social medicine was sort of like a casualty of the division between public health and clinical medicine in the U.S. And then I talk to them a lot, then I talk about alma ata and thinking about how health is a human right. And this was in 1978 that we looked at health as a human right. And look at us now, 50 years later, nearly to the date, still saying health is a human right and still being challenged by it. And then I bring up some of the frameworks that I shared with you. And then we get back to Virchow, because Virchow has actually been in the introductory or foundational lectures in nearly every introductory lecture. And then we go to this gentleman, Paul Farmer, who along with his colleagues, Jim Kim, and others, have sort of renewed the idea of social medicine as a discipline. And I would say that the pendulum has sort of swung all the way back now, where we teach and learn about health equity from a social medicine perspective, or I propose that we should do that, or we can do that. It's a nice way of framing the work. So what is social medicine? Social medicine is a practice of medicine that integrates social epidemiology, social determinants, and social science approaches to patient care, It has an advocacy and equity agenda. Like I said, health is a human right in the social medicine framework. It is an interdisciplinary, collaborative, and multi-sectoral way of practicing. And you need to have a deep, deep understanding of context to make sure that both locally and internationally to move the work forward. And finally, the voice and vote of patients, families, and communities matter in the social medicine framework. So how can we use this? I would say that you'll see that organically we do a lot of this work, but this is a nice frame that you can use to look at the work that your institution is doing and see where some of the gaps are, and if you're doing that. And you can even get deeper or more specific to education by looking at structural competency, which we'll do in a moment. But this has been going on for a while. There's a social medicine consortium, and I put the website down here. And the social medicine consortium is a collective of individuals, universities, and organizations who are working for this. They're working for health equity through education, training, service, and advocacy. But this is a mission or a philosophy as well as a framework that you can use. And this picture on the right here is just a photo I took from the back of the Health Disparities and Social Justice Conference in Chicago. So you'll see a lot of Chicago institutions are represented in this. But just this notion of many people coming together in response to calls, but also organically knowing that we need to be doing this and need to be doing it better. And how can we think about it specifically for education? Well, Metzl and Hansen came up with this term structural competency. So we're always looking for competency-based ways to teach our trainees, and structural competency has been proposed as one way to do this. So structural competency is the capacity to recognize and respond to health and illness as the downstream effects of broad social, political, and economic structures. And there's a shift in medical education, partly because of the governing bodies and academies that have made these requests that we talked about in the beginning, but also because of educators, towards attention that forces us to look at the influence of health outcomes at levels above individual interactions. So keeping that in mind, levels above individual reactions, I'm going to move through to structural vulnerability on this slide, and we'll go back. But if you look at structural vulnerability, what I like here, it's a risk that cannot be repaired solely by individual agency or behaviors. It's a result of structures. So going back, so breaking down this structural competency a little bit further, they talk about components. So you could use this to do a gap analysis of your curriculum or your course. Are students learning to recognize these influences, these structural influences? So I would say that the first two structures on patient health and structures in the clinical encounter can be done in the preclinical and maybe the early clinical years. And then the following two, structures in the clinic and beyond the clinic, you can do structures in the clinic, obviously in the clinical years, and beyond the clinic can be done really throughout, because that's advocacy teaching, which is also similar to the structural humility. So structural violence as a definition is, Paul Farmer coined the term, talking about the violence that an individual and a population experiences because of these structural and social arrangements that make their lives unhealthy. And thinking about structural vulnerability, we talk all the time about our patients' risk, a risk that they're going to have an MI, a risk that they're perhaps predisposed to cancer. But what about the risk that an individual experiences by virtue of their structures? That is something that we should be thinking about. And that it is, like I said before, it's beyond individual agency. We certainly can can support the intermediary determinants and try to make change there, but some of these are structural. So we're moving into our tools section, and so this is a really nice handout or kind of group, a little booklet that folks from Berkeley came up with, and it's called Structural Competency Handouts, and they give you a case, they give you a structural vulnerability checklist, they give you key concepts, ways to intervene, ways to think about intervening, and about a 4-page reading list, and then finally some naturalizing prompts that you can discuss with your students and structural violence prompts as well. And I want to just bring your attention to here, they wrote, please cite when utilizing and adapting to your own context, and they have exactly what they developed, but they ask you, they say, please use this. It's really helpful. And just adapt it to your context. You don't have to invent it. So I just wanted to show you, so this is sort of, there's a lot going on here, but this is the structural vulnerability checklist, and you're tasked to sort of like get in here into each domain and either change things or adapt things for your patient, the patient you're going to see at the time that you see them. And I just blew up the financial status one so you can see some ways of asking questions, you know, are there other ways that you make extra money? Do you have problems doing your work? Do you run out of money at the end of the month, et cetera, et cetera? And then residents, of course, like, where do you sleep? Do you feel like where you sleep is safe? And it is a long list, and you certainly can't get through it in one visit, but there's certainly a lot of, there are a lot of nice tools. There are other ways you can use this too. Sometimes I've used it where I'll have an expert and a sort of simulated patient or a case, and then have faculty around taking notes about exactly what kind of language someone is using. You can ask your students to use this by, before they see a patient or before there's a patient that you know is coming in, which of these domains might be important, what specific questions would you ask, and when I do that simulation and feedback where you watch an expert actually ask the questions, you write down their language and then kind of try to use it yourself. And then if you're doing this in a faculty setting, as a faculty member, do you feel comfortable or competent doing this? Do you feel efficient when you're doing this? And if you don't, what are ways to change that or improve that? And then, of course, finally, if there's a case in there, and I'm responding to the case in there, but how would you coach a student who is seeing a patient as described in the case? So these are some ways you can use this with faculty and use it with students as well. That's a really nice tool. So when I was doing the background research for this, I came across this article, and a lot of people cited it's from 2014, which isn't that long ago, but sort of seems like an older article. And a lot of people have cited this article as a nice article to think about teaching. And it's a collection of 12 tips for teaching social determinants of health. And I want to reflect back on that social medicine framework for a second. This image here is supposed to reflect grassroots. So I think organically, a lot of us are doing what is in that what is in that social medicine framework or what is recommended. Sometimes we just need a checklist of what needs to be done and how to do it well. And so, previous to, even without using the social medicine language or the cultural humility language, these 12 tips were actually a really nice way to organize teaching tools. So that's what I'll be using. So tip 1 is just define key concepts and provide explanatory models. And so that's what, we saw in the research, is everyone did that in their content. They start with definitions. So identifying social factors, these explanatory models, providing a history lesson, which I did a little bit with you, and then I'll show you, some people will use the Engels or the biopsychosocial models to talk about social determinants of health. So I just provided a history lesson a couple minutes ago as a way of teaching. And I wanted to share with you a little bit about, I wanted to share with you this slide that I use for everyone. And so this is my health equity slide. That is just my equity versus equality slide, and I wanted to share it with you mostly so that you can all use it, because I think everybody here knows what the definition of equity is, but this is one of my definitional slides. And then I'm going to go through some more resource slides that are a little bit more structural. So I really did just include this as a general definition slide. Sorry, so I think we're getting in some questions. That's why I'm pausing. But I'm going to keep going so that I get through everything, and then we'll get to questions. So in terms of structural vulnerability, I just gave you that tool. I'll go through the fishbone tool, and then I'll show you our WHO framework tool, and then next I'll go through some specific resources that we use and share those with you so that you can use them as well. So I've used, so the structural vulnerability tool we showed you, then some people have thought about thinking through health and disease using a fishbone analysis, where you push yourself to look at upstream causes. And a neat way to do this, or a neat example of this, is applying it to type 2 diabetes to see how you can push yourself to look at upstream causes and really say, like, oh, you know, low high school graduation rates, you know, will end up influencing type 2 diabetes, et cetera, et cetera. But look at how the small little bones here really point to the social determinants of health and some of the intermediate determinants of health. And the model that we use very frequently, and sort of like the picture of Vercow and the picture of the WHO framework, shows up in a lot of different introductory lectures. But this is a really nice framework to share with students and to frame all the work around, to show them the differences between structural determinants, social determinants, what things are mutable, what things are not, how can we make impact. We talk a lot about how the stuff all the way to the left really requires advocacy, and I like to think of this stuff in this box as some of the things that we can gather information about and potentially intervene on in the clinic-based setting. And so we like to show them both and to discuss what their roles can be in that space. So those are structural resources, so systematic approaches to teaching, good explanatory models, and then also using local context. And we use maps a lot, so I just wanted to show you something easy that everyone can do. There are context-specific maps, so this low birth weight map will show you real disparities between neighborhoods, and that's a local map, as well as this diabetes prevalence map. I show you these because the low birth weight map is from Chicago Health Atlas, and I imagine many of your cities, at least the urban cities, will have one. But then the one on the right is from cdc.gov, 500 cities. So these are two nice local resources. So I show you area-specific resources, and then the CDC 500 is a national resource that you can put any city in. And then there are also research-based maps. A lot of us have heard about some of the zip codes or geospatial mapping and using those to understand health outcomes and ill health effects. Here's just an example. These are all just examples of what you can use. The Child Opportunity Index is one really interesting one where where high opportunity and low opportunity are pointed out on a map based on many factors that have to do with social determinants of health, and then race is overlaid on top of it. But you can actually go to that website and put in a city. And like I said, this varies a lot. So you get a lot of this data for urban locations. use this in my lecture for the students to really make things context specific. David Ansel is a social epidemiologist and a doctor here in Chicago. He's now at Rush University, and he published this book, How Inequality Kills, and describes the change in life expectancy, or the differences in life expectancy, right along our train line here, the elevated tracks. And so you can see that between West Garfield Park and the Loop, it's the same disparity in life expectancy as Iraq and Japan. And this comes up a lot because we talk about deep disparities in the global health context, and then we bring it home to show it in the local context here. And this is a tool, I put this in here really because we actually start talking about maps by first doing just a general game. And this is a sort of side teaching tool. This is just a nice way to engage people, where we have folks have an idea of, like, what do you actually know about where your patients come from? Do you even know the names of the neighborhoods where you live? And then we move on to do a community health asset mapping activity around the neighborhoods with expert facilitators. But I put this in so that you could use it if you like. And then, service learning and experiential learning have really been lauded as one of the main ways to teach this. And as you saw, that's what many people do. And the notion is that you provide authentic experiences and teach people about critical reflection and self-reflection. And then there is information about how to do this well, how to do service learning in a competency-based way. And I wanted to share some of those with you. And that the service, the sort of best practices is that the service is community-driven. There's cultural and bi-directional learning and exchange. Think of yourself as a citizen, a global citizen, a community citizen. There's continuous critically reflective practice that's facilitated thoughtfully. There's demonstrable learning, and there's ongoing attention to power and privilege throughout the program coursework, noting that there are steep gradients in power and privilege between you as the teacher or you as a student and the patient or whoever you may be seeing in the community. And then, of course, that we provide safe programs. And then self-reflection and narrative medicine are very useful tools. I put a star here because it comes up all the time. We don't have time to deeply talk about self-reflection and narrative medicine here, but it's important. I've talked a lot about introspection and sort of knowing your position compared to your patients and what you bring to an encounter with a patient, the biases and motivations and understanding. And then finally, a recommendation is to do things in an interprofessional manner, as you saw in even that first triangle from the educating health professionals educating health professionals about the social terms of health. You need collaboration. Much of this, as you saw in the frameworks, exists outside of clinical medicine, and so you need those experts to be teaching it, particularly humanities and social sciences, and then the social workers and nurses and public health to give you some of the critical tools, and the humanities and social sciences to give you some of the philosophy. And that's what I think about the humanities and social sciences when we're thinking about narrative medicine, critical reflection and introspection, and some of our ethicists to even help us tease through how we engage with the community. And I actually, now that I'm looking at my slide, I don't really like the word help the community. I'm going to change that. I must have taken it out of the article, but to better engage with the community for bidirectional learning. So that's immediate feedback for me about how we think and how the power of language. So some examples of sort of innovative ways of thinking or harnessing some of these ideas. Medical legal partnerships have come up in the literature as a way of showing this or teaching this well. poverty simulations have been written about. There are, I think, 2 or 3 articles on poverty simulations, and we've actually talked about using it in our curriculum, but there's, you know, positives and negatives about it, and it's something that we're brewing here, but it's an innovative way. One of my colleagues, Dr. Goyle, who's mentioned in this lecture, just came up, and I just came back from facilitating a book club. So she harnesses the notion, or she harnesses experiential learning by having us read something that really reflects social determinants of health or structure, or the influence of structure in medicine, and we reflect on that. So we have deep experiences, and the book is really well written and engaging, and so there's a lot of salient emotional reactions that we can tease apart, and it brings all of the learners to the same starting point, because we have, as you know, some learners who don't know anything about this, and then some learners who are, you know, already, you know, advocates and activists. And so using the book club as a way of bringing everybody to the same place of experience, it's actually already been pretty neat. And then my job is global public health, where I try to leverage the interests that students have in global health and try to connect global and local, and sort of harness this idea of service in the global space and how exciting that is, and pushing that dialogue into the social determinants of health space. I use it in my teaching in health and society. I look at global disparities and just show them sort of like the stark, deep disparities that are present in the global space that exist on a smaller scale here, like we saw in the L, but exist on a huge scale universally. And so those are some of the innovative ways that we can use, you know, the public health space, the humanities space, the legal space, nursing, et cetera, et cetera. So what are the next steps? So we need robust programming for all students, and I think that's what's neat about some of the things we talked about in the 12 tips, like how do we use this for all students and we engage all students? We need research, we need evidence in that space. We need more research, but we need it to be disseminated. So I read a lot of really, really neat articles. However, many of them were not published in with like great detail in a way that could be replicated, or they didn't give enough information overall as to like how you would not just implement but evaluate, and so they ended up, there were little bits and pieces in a lot of articles. We need focused research and clear dissemination, and some of the dissemination is just people are innovating all these neat things, and they just need to write about it and publish it so that we can actually use it. Clearly, assessment is a bear or an elephant in the room, and we need program assessment and student assessment. How you do it in this space is a really big challenge, but we need guidance here, all of us do. We need guidance on how to make community-based education thoughtful and genuine and integrated. And I think there's a really neat opportunity to use social medicine as a, you don't have to reinvent it, as a framework to look at what you're already doing, how to do research around that, and then how to implement. And then finally, that's our little, that little puzzle piece down there is, while everybody is busily writing up their innovative curricula so they can publish it and wait, you know, a little time for it to come into publication, we're bridging the gap with this community of practice. And so we want to get things out to people who want to use them, and they may not have been published in some of the journals or, you know, kind of like made the cut for our scope and review, but they certainly have great value, kind of like the 12 tips article. And so our community of practice, one of our goals is really to just push some of this stuff out as fast as we can and as, you know, fast as we see it, to bridge the gap to the future of evidence-based social determinants of health teaching. Thank you.
Thank you so much, Ashley, for that great presentation. So at this point, we will open it up for questions. I saw that we already had one in the text chat box, but as a reminder, you should have access to the line, so feel free to just talk into the phone or type into the chat box. So I'll go ahead and read the question that was written into the chat box. So this question was, can you give more detail about presumed worthiness? And this was under the structural domains slide, I believe.
Oh, okay. I was wondering, presumed worthiness. So I guess the question, so let me, I have to go back to my slide. That's a really heavy question. Okay, so I need to go back to the slide, presumed worthiness. And I think some of this is around introspection. So, sorry. So that's one of the structural this is one of the structural competency domains? You're a good reader, whoever found that one. So I think I have to say I don't know that I feel like I'm an expert in answering the presumed worthiness. I'm just trying to, okay, sorry, that's in the structural. So are you, this one, okay, so how do you feel like, do you feel like your illness is worth, like you're a valued member of society, and that if others saw you, would they say, this person is worthy of X intervention? What I can come up with is we often have our patients who have substance abuse disorders. For example, a presumed worthiness situation could be an IV drug user potentially could not be presumed to be worthy enough of a tricuspid valve replacement. Sorry, I'm getting like super technical and clinical in there, but that's this notion of presumed worthiness. So it's this idea of like, what do other people think about their disease? Is it their fault? It's sort of that like individual behaviorist approach versus a structural approach. Is that person an IV drug user because they, never had an education, never had money, never felt supported, et cetera, versus like it's their fault for whatever reason. And so that's, and it's an important way, because you see how the world has been looking at that person and treating that person. I hope that's a good answer. This little box is helpful right here.
Are there any other questions?
Kendra, how are you?
Hi.
Still coming today?
Oh, you're not talking to me. You're
Okay,
talking to your
do you want to
patient.
see?
Just as a reminder, please mute your lines if you're not asking a question.
Okay, so how long will it take you to walk there?
That's a good example of access.
So why don't we just say we'll leave it 2, and then you don't have to rush. Okay, if they're a little late, that's fine. Okay. All right, bye-bye.
Are there any other questions? As a reminder, you can type in your question or just talk directly into the line. And in the meantime, let me take you to our last slide just for some closing remarks. So we do have an evaluation form. If you wouldn't mind, please fill this out. Your feedback helps us plan for future webinars. And then Ashley has provided some resources for teaching health equity. And so there's a link right here. If you click on that, it'll take you to more resources. And then we'd love to continue this conversation with you all, so please follow us on Twitter. There's our Twitter handle right there. And if you have any questions or comments, please feel free to email me directly at lauren.guard@northwestern.edu. And again, we will be sending out a follow-up email with attached with these slides, and then I'll include a link to where we are archiving the recording of this. If you didn't register, I don't have your email, so please send me a direct email if you'd like to be included on that. And then we'll wait a couple more minutes if there's any questions. Harrison, thank you for joining us. So we'll hang around for a few minutes. Please feel free to ask us any questions or follow up afterwards if that's easier for you. Otherwise, thank you again to Ashley.
Oh, I like that question, Jennifer. So yes, you are right. Our students absolutely say that. So they're like, thanks a lot. You just overwhelmed us with all this stuff that we can't change. So we actually try to empower them with some tools, and it's not, you know, the best, but we'll give them some resources around like NowPow, how to connect them, or have them work with social workers and nurses to see if they can change that in the clinic. Not standardized yet, but we're trying. We've started. And advocacy teaching. And so I think one of my colleagues said, you know, the students say, thanks a lot for teaching us this, but like, how do we change it? And they grassroots organized an advocacy elective at her institution. And so I think the only way that we can sort of say diagnose and treat the problem is to really teach them what their role is as an advocate, and then what their role is in the clinical encounter to advocate. But Jennifer, I had like 10 slides after this, and I'll actually send them to Lauren to put in the resource section. It's all about how different people are teaching physician advocacy at 5 or 6 different institutions, and I'll give away the ending here, but the really robust programs only do it for select students. But my answer is advocacy and interprofessional support, and really intentionally teaching that in the clinical and even like throughout medical school in terms of advocacy. That's our short answer.
Any other questions? And again, we'll be here for a few more minutes. Oh, we go.
Oh, yeah, we'll make sure I'll send them right now, even to Lauren.
We're sticking around for a few more minutes, so if you have to go, thank you so much for joining us. And again, thank you, Ashley, for that great presentation. But we will be around if you have any other questions. As always, thanks so much.